comfortable, Ravi sir?
Yes, yes, I'm fine.
Okay, that's perfect. Hello everyone and welcome to the today webinar. I guess you can hear me very well. Okay, it's me Kapil Gautam and today I'm with you all as a host for the Today I Talks program by Mero Eye Foundation, and I feel extremely privileged to welcome you all for the session. Okay, today we have a surprise. Surprise for that it means Dr. Ben Limbu also joined us for the discussion session for the panel discussion. So I would like to go through the brief introduction first. Dr. Bean is a consultant ophthalmologist and he is the assistant professor at Tilunga Institute of Ophthalmology, and he is the uh, consultant cataract and ophthalmic plastic and reconstructive surgeon and General Secretary for Nepalese Association Society for Ophthalmic Oculoplasty Surgeon and Scientific Secretary of Oculoplastic Society for South Asia and section editor for Nepalese Journal of Ophthalmology and editor-in-chief in I, I Plastic Asian Pacific Society of Ophthalmic Plastic and Reconstructive Surgeon. Doctor, I would like to welcome you for the today's session.
Thank you very much.
Thank you, sir. So without being delayed, I would like to move towards the presentation. Today's topic for discussion is evaluation and management of Ptosis. And speaking delegates, we have Mr. Ravi Shankar Chaudhary, sir. He is the only one consultant ocularist here in Nepal, and he is currently associated with Drishti Eye Care System. So, without being delay, I would like to over this screen to the Mr. Ravi Shankar, sir. Over to you, sir.
Thank you, Kapil, for a good introduction. So today I'm going to discuss about Ptosis evaluation and its management in brief. And we have a great personality with us, Dr. Ben. So he'll be always guiding me in my presentation if anything has to be added. So I think Ptosis is not a new topic. It's a very repeated topic what we are listening. But what I will be focusing in my presentation is what's as a optometry part, what we should do while doing Ptosis, and what is the usefulness of doing that workup for Ptosis. So before going in the Ptosis evaluation, short brief introduction about eyelid anatomy. So coming to the eyelid anatomy, if we see this diagram, we have the main thing for eyelid elevation is the levator palpebral superioris muscle, LPS in short. So if you see these LPS muscles originating from the back of the orbit and joining to the apex of our extraocular muscles, so this is the main muscles which is responsible for eyelid elevation. So if due to trauma or due to aging, if there is any damage to LPS, so mainly the Ptosis occurs. In a few of the times we have the other muscles responsible for lead elevation is Muellers muscle. So Mueller muscles also helps in elevation, like 2 to 3 mm of the elevation of the eyelid. So Mueller muscles, if you see, it modifies in the joining of superior like levator palpebral superioris with the tarsal plate of the muscle. So it modifies there and joins levator palpebral superioris, so it helps in the retraction of the eyelid. So well, these two muscles helps in the lid retraction. So if there is damage in this, so there will be the Ptosis. Ptosis in short, what is Ptosis means? Drooping of upper or lower eyelid. So if the eyelid from the normal position it falls down, so it is termed as Ptosis. So coming towards the LPS. So LPS means levator palpebral superioris. It is main muscles which is responsible for lead elevation. And I had shown you in the diagram, it arises from back of the orbit and extends forward over the cone of the eye muscles, and it is supplied by superior division of oculomotor nerve. And the other muscles which is responsible for eyelid elevation is the Muellers muscles. And Muellers muscles uh, uh, is uh, situated in below the LPS, which modified by the underlying. So if you see, the LPS attaches to the tarsal plate and is modified by underlying Mueller muscle. So Mueller muscle is just beneath the LPS and tarsal plate attachment. So it has also the capacity of Titan and which raises the lid in few millimeter. Few millimeter means around 2 to 3 millimeter. It helps in the elevation. So other is the frontalis and orbicular oculi. So both is supplied by the facial nerve. Frontalis contraction helps to elevate the eyelid by acting indirectly on the surrounding of the soft tissue. So what happens, so when frontalis acts, so there will be the contraction in the surrounding tissue. So in that tissue, due to the contraction, there will be few elevations of the lid. So it also helps in few uh, millimeter of lid retraction, frontalis muscles. Whereas the orbicular oculi helps in contraction or depresses the eyelid. So this is the orbicular oculi is only the muscles which helps in the uh, contraction of the eyelid. So whenever you close the eyelid or you want to contract the eyelid, so that time the orbicular oculi contraction helps to contract it. So coming to the ptosis definition, means it's the drooping or falling of upper or lower eyelid. It is defined as ptosis. So generally, ptosis is classified into three types. It is congenital, acquired, or pseudotosis. So we'll be discussing about detail of this ptosis in further slide. So coming first to the congenital ptosis. So again, the congenital ptosis will be has been divided into three basic types. So that is simple congenital ptosis. One is the blepharophimosis syndrome, and third is the congenital synginosis. So first is the simple congenital ptosis. So simple congenital ptosis means only ptosis will be present since birth. If you see in the first picture, there is the drooping of upper eyelid in the left eye. So and he had this drooping of upper eyelid since birth. So it is a simple congenital ptosis. There will be no other component related. But the second one, if you see in this picture, blepharophimosis syndrome. So blepharophimosis means there will be drooping of upper eyelid in the both, mainly in the both eyes. This blepharophimosis syndrome will be there, and along with it, there will be the other components involved. So like if you see the epicanthal folds there, so there will be the frequent epicanthal fold present in this blepharophimosis syndrome. Other one, the a flat nasal bridge. This due to this flat nasal bridge, what will be there? There will be the appearance of isotropic appearance of the eyeball. So there will be flat nasal bridge. Epicanthal fold will be there, and sometimes the telecanthus will be also present. Telecanthus means the temporal retraction of the temporal canthus. So that is the telecanthus. Epicanthal fold means the fold present here in the nasal side. Uh, so the fold is called as the epicanthal fold. And the third one is the congenital synkinetic ptosis. So in this, what will be there along with the ptosis, the other components other nerves will also involve in that. So what happens whenever you move your jaw or move whenever the patient move the jaw or move their mouth while chewing, or if you see this picture while moving the jaw, so there will be the change in the size of the drooping of lid. So whenever they move their they chew their mouth, so the ptosis will be corrected, or whenever they move the jaw, the ptosis will be corrected, or the eyelid will be elevated up, or whenever they opens their mouth. So there will be like three types. Like one is the opening of the mouth, other is the chewing, chewing of like chewing anything, and the third one is the moving the jaw. So three types generally. So if in these types, if there will be like the lead retraction will be there or ptosis will be corrected, so that is termed as congenital synkinetic ptosis. So uh, generally in basic type there will be three types of congenital ptosis. So coming towards the acquired ptosis, so acquired ptosis means are like neurogenic, myogenic, aponeurotic, mechanical, and neurotoxic. So uh, generally in old age or in sometimes in adult age we get ptosis. So that is termed as acquired ptosis. So if like only third nerve or facial nerve involvement will be there, generally mainly due to, I have seen, due to trauma. So in that cases, like neurogenic, it is termed as neurogenic ptosis. One is the myogenic. If there the muscles are involved in LPS muscles, Muller muscles, or Frontalis muscles involvement will be there. So that will be like myogenic ptosis. Aponeurotic means due to aging. Due to aging, whenever the LPS at there will be LPS detachment will be there. So LPS is always attached to a pulley, and due to like age, there will be detachment of LPS from the uh, uh, from from that pulley. So that time it is termed as aponeurotic ptosis. The fourth one is the mechanical. So mechanical means if it is like multiple callation will be there, sometimes stye or any tumors will be there in the upper lid. So due to the weight of that, there will be the drooping of lid. So that is called as the mechanical ptosis. Neurotoxic means sometimes like a snake bite, or sometimes the bee. If you see any insect bite will be there, or if you see if a like person drinks heavy alcohol, so that time also there will be like some drooping of leaves. So that is termed as neurotoxic ptosis. So these are the few types of acquired ptosis. And now coming to the pseudotosis. So pseudotosis means generally this ptosis, pseudo means, it is the false appearance. So pseudo means false appearance, ptosis means drooping of upper eyelid. So what happens if you see the microophthalmos? Uh, Microophthalmos, what happens? There will be a small eyeball. So due to the small eyeball, the eyelid doesn't get its support. So due to the because it is not getting the support, there will be the drooping of lid. So that will be like that will be appeared as ptosis. But whenever there will be like, if you see the first picture, so this is the lady with microophthalmos in the left eye. If you see the picture, that is the ptosis appearance is there. But when I fitted the ocular prosthesis in that, the ptosis was corrected. So this is like uh, whenever due to on support, the ptosis will be appeared, but when the prosthesis was fitted, the ptosis was automatically corrected. So this is termed as in the pseudotosis. Now the contralateral proptosis. So one eye is like proptosed outward. So one eye is proptosed outward, so automatically the other eye seems to be the smaller. So it is like appear like other eye is a small, and like other eye is ptosis. So actually that eye is not ptosis, the other eye is little bit proptosed outward. So if you see in the second picture, the this right eye is proptosed outward, so left eye is appearing small. So this is also termed as pseudotosis. So that is the contralateral, due to the contralateral proptosis of the eyeball. And the third one, the third picture, if you see the dermatochalasis means the loosening of the skin over the eyelid. So due to the age, if there will be like loosening of, or the fat bags will be collected. If you see the bag in the lower lid also, and in the upper lid also, if you see the loosening of the skin, due to loosening of the fat bag like appearance will be there, and it will, if you see this appear as like a ptosis. But whenever the blepharoplasty or will be done for this patient, the ptosis will be corrected. So this is also termed as the pseudotosis. So these are the few of the cases in which the pseudotosis appearance will be there. Actually, the ptosis will be seen, but ptosis will not be present. Whenever the treatment of that case will be done, the ptosis will be automatically be corrected. So this was about pseudotosis. Now this was the ptosis is a vast topic, and it cannot be compromised in a short lecture. So in that types also has different every types has different mechanical etiology and management. But in short, that was about the types of in basic, that was about the types of ptosis. Now coming towards the evaluation, I will be mainly focusing about the evaluation of the ptosis, because we need to very as a being a optometry, we need to very focused about why we are doing this workup and what is the role of doing this workup. So coming to us the evaluation part. So in evaluation, if you see, the first thing is the history. The history only suggests some of the, most of the time the history will tell you which type of ptosis is that. So in history, first thing, that is the age of onset. The second thing, duration, since birth, since like 10 years, or since after trauma. Since how many years is that, that duration has to be noted. The second one is the diurnal variation. So diurnal variation, why diurnal variation is important, I'll be telling you about. I think one of the type uh, I have missed, that is the Marcus gun. So in that and that is the one fatigue test has to be done for the, for checking the diurnal variation. So diurnal variation means what, like in daytime the ptosis is corrected, in morning time the ptosis will not be there, but while coming towards the evening time the ptosis increases. So in myasthenia gravis, generally this type of this diurnal variation will be there. So this diurnal variation history is also very much important. If the patient comes with ptosis, so you need to ask, is the ptosis will be similar in whole the day, or sometimes in morning the ptosis get corrected and evening the ptosis increases, or morning the ptosis increases and evening get decreases. So that diurnal variation history is also important. And the other is the one or both eyes. So what they notice, in one eye is small, or both eye they feel small, so that history has to be taken. Now the associated history is also very important. Associated history means with the ptosis, is diplopia is also present or not, sometimes dysphagia is present or not, muscles weakness is there or not, sometimes dizziness is there or not. So this history along with ptosis, this all is present or not uh, for the patient, that need to be noted down. Now the association with, along with the ptosis, the jaw movement. So while doing the jaw movement, the ptosis get corrected or not. Sometimes while chewing the sometimes eating meals, the ptosis get corrected or not. That history also has to be asked. Now the abnormal head posture, like head tilt, face turn, is there any is the head turn, head postures is normal or not. Now the abnormal ocular movement, like sometimes like patients look isotropic, or sometimes is there any deviation of the eyeball or not, uh, the patient noticed that or not. So these things has to be noted down, and this all has very much significant, which type of ptosis is that, what type of management has to be done further. So this if we take this history from the first thing, the it helps in the diagnosis, it helps in the management part. Now coming towards the history of, so history of due to trauma or any previous surgery, like sometimes what happens, if any cosmetic surgery is being done, and due to the uh, traumatic detachment of LPS, sometimes ptosis can be there, or sometimes any bike accident, and if there is trauma in the LPS muscles, so there that time the ptosis can be appeared. uh, any history of poisoning is there or not, sometimes during suicide, they sometimes they take poisons, or sometimes like mistakenly they have taken any poison or not, so that history also has to be taken. Use of steroids, overdose of steroid is there or not, and any drug allergy. So any drug allergy is there or not. Sometimes due to if there is any drug allergy, short drug allergy, that also can induce ptosis for short period of time. So this history also very important uh, for diagnosing and management of the ptosis. Now coming to us the measurements. So these are the workup or measurement we can tell which we need to perform for the ptosis, and this helps us mostly in diagnosing and which type of surgery has to be done. So ptosis also has different types of surgical managements. Which type of surgery has to be done, that is also decided by this measurement. So these are the marginal reflex distance (MRD), vertical fissure height, lead crease distance, lag of thalamus, Bell's phenomenon, and LPS levator palpebral superioris action. So about this detail in further slide we'll be discussing. So coming to us the vertical fissure height, or that is in other term palpebral fissure height, also it is termed as palpebral fissure height. So vertical fissure height can be measured in three types. So first one is the primary gaze, the other is the up gaze, and third one is the down gaze. So what is vertical fissure height, we need to understand. So in primary gaze, if you are measuring vertical fissure height, means we tell the patient to look in the primary gaze, we give the fixation, and we measure with the scale. So the upper lid margin to lower lid margin, if you see in the diagram, the distance between upper lid margin to lower lid margin, so that is termed as vertical fissure height or palpebral fissure height. So this is whenever we give the patient target on primary gaze and we measure the distance, so this is called as the vertical fissure height in primary gaze. The second one, we give the target in up gaze and we measure same the distance between the upper lid to lower lid, so that will be like primary gaze vertical fissure height. So and in the same way we give target in the down gaze and we measure the distance between upper lid to lower lid, so that is termed as the down gaze vertical fissure height. So generally there is a grading described in a literature uh, about the severity of ptosis. If the difference between the this palpebral fissure height or vertical fissure height between the two eyes is 2 mm or less than 2 mm, it is called as mild ptosis. Less than or equal to 2 mm is mild ptosis. If it is more than or equal to 3 mm, it is moderate ptosis, and if it is more than 4 mm of difference between the two eye, that is called as the severe ptosis. So this is the grading of the ptosis done. So if the difference between both the eyes is more than 4 mm, that is called as the severe ptosis. So coming to us the marginal reflex distance. What is marginal reflex distance? And the other thing, why we do the vertical fissure height? So why we do vertical fissure height? While measuring the vertical fissure height, it tells you that how much ptosis is present. First thing, and the second thing, like how much ptosis has to be corrected. That like in one eye it is 10 mm and in other eye it is 7 mm. So which type of ptosis is that? It is mild ptosis, moderate ptosis, severe ptosis. So it will be like moderate ptosis, and how much mm has to be corrected, that is the 3 mm. If the one eye palpebral fissure height is 10 mm and other eye is 7 mm, so it should be like equal to other eye, 10 mm has to be done there. So that 3 mm difference is there, so that 3 mm has to be corrected. So it is directly related while performing the surgery. So whenever the surgeon performs surgery, so how much has to be corrected, so that also is signified by the vertical fissure height. So this is important for that. Now the marginal reflex distance. So what is marginal reflex distance? So in marginal reflex distance, if you see this picture, whenever the everyone know about the pupillary reflex, right? Whenever we throw a light, there will be a pupillary central reflex. So central pupillary reflex. So the distance between pupillary reflex and the upper lid margin. So that is called as the marginal reflex distance. So the normal range of marginal reflex distance is 4 to 5 mm. So this distance between this pupillary reflex to upper lid margin, so that is marginal reflex distance. So generally in a grading, so mild ptosis is if it is 2 mm of the droop, like if it is like 4 mm has to be there the marginal reflex distance generally, and it is 2 mm, so 2 mm of the droop is there, so that is will be the mild ptosis. If it is there is 3 mm of the droop, so moderate ptosis, and it is more 4 mm or more, that is the severe ptosis. So if you see the four picture, if you see the difference between the marginal pupillary reflex and marginal lead margin, so that is near about 4 to 5 mm. If you see the second picture, it is less than the first picture. If you see the third picture, it is nearly about 1 mm. It is just above the pupillary reflex, and the third one, the last one, the pupillary reflex is also covered. So if the pupillary reflex is covered, how much mm the pupillary reflex below the pupillary reflex is there? So we retract the eyelid, we put the scale near the pupillary reflex, and again after that we lift the eyelid. So how much of the from the pupillary reflex, how much down is the lower lid margin? So that will be like the drooping of the lid. So whenever it is in the upward portion from my, if it is pupillary reflex and marginal reflex distance is, the lid is above the marginal above the pupillary reflex, it will be signified in the normal plus value. And if you see in the fourth picture, if the upper lid is covering the pupillary reflex, then we measure and we see how much of the drooping, how much of the covering of pupillary reflex is there, and we measure it in the minus. If it is suppose like 1 mm below the pupillary reflex, so we will mention like -1. If it is 2 mm below the pupillary reflex, we'll measure like -2. So in that way we write marginal reflex distance value. And what is the importance of that? If sometimes the patient while measuring the palpebral fissure height or marginal reflex distance, what happens, sometimes the patient can move their head or sometimes move their chin, so the reading can be little bit variable. So again, to confirm that the how much of the ptosis is there, the marginal reflex distance plays a very important role. How much ptosis is present, actual how much ptosis is present there. So this is the other way, how much ptosis is the present and how much has to be corrected during the surgery, that also is signified by the marginal reflex distance. Now the third one is the lead crease distance. So the lead crease distance means, if you see the picture, so always there will be a fold of lead crease fold will be seen in the skin above the upper lid. So that the prominent lead crease seen in the eyelid. So the distance between the prominent lead crease to the eyelid margin, so that is called as the lead crease distance. If you see in this picture, the prominent lead crease is covered by this dermatochalasis, so we can uplift this and we can measure this. But here the prominent in the ptosis, the prominent lead crease is there, so the distance between this lead crease and the margin of the lead margin is called as the lead crease distance, the difference between these two. And what is the importance of doing that? So the importance is like, while doing the LPSR, means levator palpebral superior retraction surgery, the a type of ptosis surgery, we make a incision. So that incision has to be covered. So whenever if it is done in that fold, so the scar of that incision will not be seen to others. So for that, the lead crease is very much important. And the other roles of the lead crease is The absence of lid crease means generally it is a type of congenital ptosis. If it is a high lid crease, like normally it should be 6 to 8 mm, but it is a 10 mm lead crease distance or 12 mm lead crease distance. So in that cases, we can feel that it is a aponeurotic or senile ptosis. And if there is no lead crease present generally, so that will be like congenital ptosis. So types of ptosis can be also verified by lead crease distance, and generally it helps during the surgery to uh, so that the the surgical scar will not be seen. The other is a LPS action. So LPS means the levator palpebrae superior. So this is the muscles. So how much the muscles action is present. So how to check that? So this is the Brooks method. So how to check the LPS action? So what we do, we put a thumb near the frontalis of the lid. So near the eyebrow temporal side there will be frontalis present, so that we press it, and after that we tell the patient to look down. We put the scale near the lid margin, and after that we tell the patient to look up without moving their head. So whenever the distance of lead from down to up in the scale, like if you see in 0 mm we have kept in the first picture, and in the second picture whenever we told the patient to look up, it is in the 12 mm. So 12 mm is the LPS action for this patient. So generally normal is like 15 mm or more is normal. Good is like 8 mm or more. 8 mm or more is also good. Sometimes fair is 5 to 7 mm, and poor is 4 mm to or less. So what is the role of this LPS action is, while doing surgery, which type of surgery has to be done? So generally there are two types of surgery, like LPSR, levator palpebral superior dissection, and like frontalis sealing. So if there is like LPS action is very poor, so that time the frontalis sealing is done. And if the LPS muscles action is good, so LPSR can be done. So this LPS muscles action is very much important, and we in one time we can get the false results. So we need to repeat 2 or 3 times. Tell the patient to look down, put the scale, and tell the patient to look up. So the distance covered by lead from down to up, so that will be your LPS action. And the one thing very important is that we put a thumb near the frontalis. Why? So as I have described in the anatomy, the frontalis also has 2 mm or 3 mm of the retract helps in the retraction of the eyelid. So we need pure action of LPS. So we put a thumb there near the frontalis muscle, so that the frontalis muscles action will be paralyzed, and we get a pure LPS actions muscles action. So this putting a thumb is also very much important. Sometimes the if the patient uses the frontalis, the over action of LPS can be seen, because the frontalis will be also acting along with the LPS muscles. The other is the lag of thalamus. So lag of thalamus means the inability to close the eyelid. If you see in the picture, the patient is not able to close the eyelid in the like without forcing, the patient is not able to close the eyelid. So the distance between upper lid and the lower lid tells you tells you the lag of thalamus. In other term, incomplete closure of the eyelid. So that is also called as the lag of thalamus. If we segregate lag and ophthalmos, lag means gap, ophthalmos means eye. So the gap in the eyelid is called as the lag of thalamus. And why this is important to measure? Because if some patient has lag of thalamus prior the surgery only, so after surgery there will be the expected 2 or 3 of the lag ophthalmos during the LPSR, and in frontalis ceiling there will be more lag ophthalmos. Expectation of lag ophthalmos will be more. So if the patient already has lag ophthalmos and you post for the surgery, there will be the extreme lag ophthalmos. So what happens? The patient has done the cosmetic surgery and there will be the other problem. Corneal issue will be there, SPKs will be there, the corneal can be the corneal exposure it can go in the corneal exposure keratopathy. So other problem can be created. So there is the role of measuring the lag ophthalmos. If the lag ophthalmos is present, that will not be the good case for the ptosis surgery. So now the Bell's phenomenon. So what is Bell's phenomenon? Bell's phenomenon means while closing forcefully the eye, how much of the cornea is exposed. So that in that way we check the Bell's phenomenon. So there is a grading of good, fair, and poor. So if like more than two to third of the cornea is disappeared, to cornea is not seen, so that will be good. Fair means if like 1/3 or to 2/3 of the cornea disappear, then it is fair. And poor if the less than 1/3 of the cornea disappear. If you see more than 2/3 of the cornea is disappeared in the picture. So how to do? We tell the patient to close the close the eye, and we try to open it. And after that, we see how much of the cornea is exposed. So if you see in this picture, this lady has good Bell's phenomenon, and it again can be of 3 types: inverse Bell's, reverse Bell's, and reverse Bell's. Inverse Bell's, generally in most of the cases there will be inverse Bell's, means upward and inward. Whenever we tell the patient to close eyelid and we try to forcefully open it, the eyeball will go towards the up and out. So generally upward portion generally. So there will be the upward and inward. So that is called as a inverse Bells, and reverse Bell means down and out. So that will be the reverse Bell, and reverse means different direction, like sometimes going in up and down, sometimes going in middle. So in very rare case the reverse Bells will be there. So this bells, to check the bells is also very much important. Why? Because I told you that there will be the expected lag ophthalmos after ptosis surgery. Mostly in some of the good surgeon, there will be very minimal lag ophthalmos also present. So if we check the lag ophthalmos, like if there will be lag ophthalmos after surgery, the cornea will be exposed or not. If the patient has poor bells and you do the ptosis surgery and there will be lag ophthalmos, and the patient can go in the other corneal disease like corneal exposure keratopathy or SPKs and dry eye. So this problem can be there to the patient. So checking the bells before surgery also has a very important role. Now coming to us the eyes test. So what is the role of eyes test? So one a type of ptosis I have missed is the myasthenia gravis. So myasthenia gravis, what I have told you, we check the diurnal we ask for the diurnal variation. We ask for the patient that your ptosis is equal whole over the day, or sometimes it's correcting up and sometimes it getting worse. So that can be like the other nerve problem along with the ptosis. So to check that is the ptosis due to LPS action, or that is due to the other nerve issue. So for that we check the eyes test. So eyes test, what we tell, we take the prior measurement, all the vertical fissure height, the marginal reflex distance, that all things we measure, and after that we put a ice pack over the eyeball for 2 to 3 minutes, and after that again we do the measurement and we see the difference between the measurement. If there is more than 2 of the difference in the measurement, like in vertical fissure height or marginal reflex distance, then it says that it can be it can be it is not a pure ptosis only, it can be the other neurological issues also. So it can be like myasthenia gravis. So this is the clinical test which we do to rule out myasthenia gravis, and there are the other tests which we do in the OT by uh, injecting a injection in the like eyelid, and we check for the, again we see the same difference between the palpebral fissure height prior and that test. So, and this eyes test is the very clinical test which gives us a very good result. If you do the test very nicely, it can give you the very good result. So if there is difference between the measurement between the like before eyes test and after eyes test, if you see this picture, the in the first picture the patient has complete ptosis. If you see the palpebral fissure height, it is around 4 to 5 mm, and we have done the ice test. So while doing ice test for 2 to 3 minutes, we put the ice back over the eyelid, and in the third picture if you see, the ptosis has been corrected and the palpebral fissure height is around 9 to 10 mm. So there is difference between the measurement, more than 2 mm difference is there. So we have to do other test for to confirm that either it is a myasthenia gravis is there or not. So this test help us to check to rule out the myasthenia gravis. Now coming to us the management part. So I think management part I'm not so much expert in management part. So in short, I'll be telling you for the mild ptosis, most of the time, because it will be like the cosmetical issue, so we can absorb it, we can ask the patient to absorb it, or sometimes the Muellerectomy. I told you the Mueller muscles also have the 2 mm or 3 mm of the action. So like if it is a 2 mm of the ptosis is there or 3 mm of the ptosis is there, so Muellerectomy can be done, or LPS resection. So LPSR is the other surgery, that is the levator palpebral superior resection. So tightening of the LPS. So in that, uh, how much of the in my mild ptosis that can be done. In moderate ptosis, again the LPS resection is the a type, and the levator advancement is the other type which can be done in the moderate ptosis. So in first only we need to diagnose either it is a mild ptosis, moderate ptosis, or severe ptosis. So like I told you, the difference between like 2 mm of the 2 mm or equal to 2 mm is like mild, more than 3 to 4 mm is moderate, and more than 4 mm is severe. So how much of the ptosis is present, according to that the surgical plan generally is done. So if it is a severe ptosis, the LPS resection doesn't work in that. So in that cases the frontalis sealing is done. So frontalis sealing means what happens, the frontalis muscles is tightened to the tarsal plate, and that holds the upper lid upward. So again, all has its advantages and disadvantages over that which surgery has to be done. There are so many literature over that, which one is best, which one is giving the better result. But this in basic, in short, these are the few surgery which is done for the ptosis management. So this was from my side. Thank you. And I think the missing part can be added by our senior Dr. Ben in the surgical part and in the evaluation part also. And any queries we are open to take. Hello.
Okay, thank you so much, Ravi sir, for such a wonderful presentation, and thanks to the all attendees for their participation and presence. So I would like to move to the discussion round or panel discussion. Let me check how many questions you have arrived on the comment section. Okay, I would like to go with some question. Are you comfortable with the question, Ravi sir?
Yes, yes.
Okay. So Asmita Maran asking for the question. So thank you so much, Asmita. She's asking for how to. Okay, can we get more clarification about differentiating between the aponeurotic and dermatocalcitosis?
Aponeurotic and
Dermatocalcis.
so aponeurotic means like generally aponeurotic means due to the it is also a type of acquired ptosis only, and it is due to the detachment of LPS. But in dermatocleistosis means there will be like that will be like pseudo appearance of the ptosis. The ptosis will not be present, but due to the loosening over the skin of around the eyelid, so that due to the there will be a bag like things will be created, and that due to that the mechanical ptosis appearance will be present, will be seen, but the actual ptosis will not be present. Whenever the surgical things will be done, the dermatocleistosis will be corrected.
Okay. So Dr. Bain, do you like to add something over it? Okay, just let me, I guess he can't unmute himself this minute. Let me check the setting once. That is just a minute. Okay, let me check the setting. Mm-hmm. Okay, just a minute, doctor. I'm working for it. Okay, so okay, Dr. Bean, can you please unmute yourself? Now I guess you can do it. Okay.
Yeah, thank you, Kapil, and wonderful presentation by Ravi Shankar. He's a good presenter as always. So, regarding the ptosis, it's a big topic, and then Ravi has covered it well in a short time. Actually, it's a kind of whole day program when you come and talk about ptosis. So, but anyway, we need to take in account whenever we think of ptosis, we need to take in account few things like congenital ptosis should be differentiated with the acquired ptosis. Okay, whenever you evaluate a patient, you have to judge yourself whether this is a congenital ptosis or this is a aponeurotic ptosis or acquired ptosis. And then other are like complicated ptosis that may be myogenic, like myasthenia gravis, or Marcus Gunn jaw winking phenomenon, or it may be associated with myasthenia gravis. So these are kind of complicated kind of ptosis patients. So we need to differentiate whether these are complicated patients or just aponeurotic or congenital. So you have to ask in the history if it is present by birth. Most likely this is a congenital ptosis. Okay. But other way of differentiating congenital from aponeurotic is, in most of the time, congenital ptosis have very less levator function test, as Ravi Shankar has demonstrated that you have to press with your thumb over the forehead so that you neutralize the frontalis action, and then ask the patient to look down, and again ask the patient to look up, as much as patient can look up. Okay, that's called eyelid excursion or levator function. If the levator function is good, that may be not a case of congenital ptosis. Usually congenital ptosis are like less than 5 or 4 millimeter of levator function. So you can guess that this may be a congenital when the levator function is really poor. Again, coming to the eponeurotic ptosis, the treatment and management of ptosis is different. Like if it is congenital, most of the time they need sling surgery, frontalis sling surgery with a silicone rod. Name is misnomer. Okay, we say silicone rod, but it is not actually a rod. It is a rubber, kind of rubber tube, and that will help to pull the eyelid with the help of a tarsal plate, because we anchor the sling into the tarsus and pull it over the frontalis muscle. So it's something like taking out of water from the dew. So yeah, whatever amount of pull you want, you can do, but you have to be careful that the exposure has to be minimized. Regarding the eponeurotic ptosis, in congenital ptosis, the main pathology behind the congenital ptosis is replacement of fibrous part of the levator aponeurosis by adipose tissue. Fat replaces the normal fibrous tissue in congenital ptosis, whereas in eponeurotic ptosis, there is dehiscence, means there is a not complete detachment, but there is weakness of the levator attachment to the tarsal plate, or there may be a complete separation of levator from the tarsus in acquired or eponeurotic ptosis. Whereas myasthenia gravis has different pathology for ptosis, as well as the Marcus gun jaw winking phenomena is again different issue. The difficulty in myasthenia gravis is we don't need to do any surgery if it is treated on time with oral medicines that's used in myasthenia gravis. So that can take care of ptosis. So that means if we ask myasthenia patient to go for ptosis, and if we do ptosis, that's a blunder because we are doing wrong thing. The levator resection surgery would not work in myasthenia gravis, because in myasthenia gravis the levator functions are variable. Sometimes it shows 2 millimeters, sometimes it shows 6 millimeters, sometimes it shows 10 millimeter. And sometimes if the person who is judging for surgery take in account like 10 millimeter of levator function and then go for levator resection surgery, it's not going to work for that patient. So be careful whether your patient is either a case of myasthenia gravis or not. So to differentiate it, as Ravi Shankar has said, it has variable presentation. So in the morning, they have good levator, good eyelid opening. But as the days pass, and then they feel like, oh, after tired, they feel like my eye is going really bad and small, and ptosis severity increase in daytime. That may be a case of myasthenia. So you should wait. If a patient give you a variable history, like doctor, I have morning, I have less ptosis in compared to evening, then that may be a case of myasthenia, and that doesn't need surgery actually. That patient need a neurophysician consultation and treatment for myasthenia, and that can take care of ptosis actually. In Marcus gun jaw winking phenomenon, the patient has a kind of connection between the muscle of mastication, which means by which we masticate, so the muscles are buccinator and other muscles. Those muscles also has the connection for same connection as of third knob. Third knob actually helps to lift your eyelid. So the same knob will come and connect accidentally to the muscle of mastication, and then whenever the patient chew or move their jaw, then eyelid opens, because the stimulation works for both eyelid and then also the muscle of mastication. So in this patient, we have to very clearly tell the patient that you may be having a Marcus gun jaw winking phenomenon even after the surgery. That has to be explained properly to the patient. And then you should always consider the eye spectacles, as Dr. Ravi Shankar has said about that. And then other thing regarding Ptosis surgery is a protection after the surgery, because exposure keratopathy is one of the worst thing to see in Ptosis surgery. So you need to be very carefully see whether the patient has good protective mechanism after the Ptosis or not, like orbicularis function, Bell's phenomenon, extraocular movement. These are actually protective mechanism of the patient's eye by where even if you elevate the eyelid, and if the patient cannot close the eyelid, then also their eyeball can be protected if they have good orbicularis function, if they have good Bell's phenomenon, and if the extraocular motility is normal. But if any of this is impaired, you should always think that the patient may land up with severe exposure keratopathy after the surgery. So you need to tell the patient before you send it. Similarly, as already we explained that levator function is very important to decide so as which surgery has to be done. One is levator resection. Levator resection has better results in context of exposure keratopathy because it has less exposure keratopathy, no lag of thalamus, and there is no lead lag in levator resection surgery. Whereas if you do a frontalis sling surgery, it's unnatural. We sometimes call it as unnatural surgery because when patient look down, the eyelid will remain up. That's what is called as lid lag. And then patient cannot close their eyelid when they are sleeping. When they are sleeping, they cannot close their eyelid, and that's called lagophthalmos. So they have more chances of exposure keratopathy in compared to levator resection where you don't find these problems. And then when seeing a child with a ptosis, that's a special condition, okay? Because there is a chance of amblyopia because of the ptosis. So if you see a ptosis in a newborn, you light and then see if child is looking at the light. And now you can compare with the other eye. If the other eye you have good reflex, you can see the pupil. That means that's not obscure. Whereas in a ptosis eye, you may not be able to see the torch light reflex. Okay, if you cannot see the reflex, if you cannot see the Horsbach reflex, then probably this child has embryogenic ptosis. So now this is the time to decide and then send the child as early as possible to prevent amblyopia. So ptosis in a children, especially a newborn, is a special situation we must consider as a emergency to refer the child. I think these are the most of the things that we need to consider when we go for surgery. If you people have time, I can show you a small video that I have done in one of the presentation, and then I can conclude my talk after that. Do you have 5 minutes more time?
Sure, doctor, we can, yes.
So I'm going to share my computer now. So here it goes. Can you see it?
No, doctor. Okay, can you please, Ravi, share
Can you see my
screen? Okay.
Yeah, I think Ravi need to unshare his screen
Yes.
first. Ravi, can you do that? Okay.
Oh yeah, continue. Yes, I guess we can. Yes, we can.
You can see that, yeah? I think this is one of the presentations that I made long time back in 2018. I think it was in DOS conference. So I'm going to show you the same. So the main thing that this is a video, this is a presentation for levator resection, which is also called natural surgery. it gives better results in term of outcome after the surgery, because there's no leg ophthalmos, there's no lid lag, and then patients are happy with the surgery. But this is not always done for all the patients, because as I said you, this is done only for the patients who have levator function better than 5 millimeter. So these are the photo where I'm trying to show different, like the eyelid incision, and then trying to expose the fat here and trying to dissect further. And then this is one of the patient who immediately after the surgery who got very good excursion of the eyelid. There's a fat pad, that's what I'm showing, and just below the fat pad there is a levator muscle, and that has to be anchored to the eyelid, and that will give whatever the amount of anchorment you make or whatever the amount of suture you apply, the length of the levator excision will decide what amount of eyelid elevation you can do after the surgery. So these are some of the steps that I was trying to show, and these are some of the results. You can see that the left eye is ptosis, and then this is congenital ptosis, but her levator was good, so I attempted levator resection, and this is what she looks like. Similarly, this guy has a right eye ptosis, and then this is how he looks like after the surgery. And another case, one after another. So these all are ptosis patients. So this is actually a child with allergic conjunctivitis for a long time, and then she developed ptosis in one eye. So we did ptosis surgery. This is another one with the prosthesis. Because of the chronic irritation, prosthesis will give a lot of mechanical friction between the levator, and then the prosthesis can lead to ptosis actually. And the same thing happened to one of my patients, and then I did the ptosis surgery. That's immediate result. And then this is another bilateral ptosis, and then there is a video actually how we do a levator resection. We give local anesthesia, so the patient will not have to be on fasting. It's all under local anesthesia. It's daycare surgery. We expose the levator. We are just at the plane of fat now, and there is a levator. Can you see that just white part? Yeah, that's what I hold it now. That's a levator muscle. So you can check. We always check the levator. Most of the time people will not find the levator because of inexperienced surgeon will have a lot of difficulty finding the levator. So separation of levator from down with the conjunctiva, and then finally we put a suture here. Now you'll see that's a tarsus. Can you appreciate that white one is tarsus right here, and this is levator, and this is tarsus. This white is tarsus. So now I'm anchoring a suture into the tarsus, and then checking it whether it's passed through or not. Sometimes it is passed through through the conjunctiva. We need to make sure that we don't do that, otherwise it will irritate. So now that bite of levator will decide the amount of ptosis correction. So, and then finally we just cut it and then close the skin, and then immediately you can see that the lid has lifted up. It's usually a 10 to 15 minutes procedure if done with the experience, and then patient can get better results with ptosis. Most of the time, the ptosis will give under correction. So this is one time surgery on the right side, and then another time surgery on the left, and then both the eyes are corrected here. So ptosis surgery will give always under correction. Under correction are very much common with the ptosis, but sometimes overcorrections are also common on ptosis surgery. So overcorrection are especially very rare phenomenon, and overcorrections are usually needed in the initial time of surgery. I mean, we always overcorrect the patient because there will be a tendency of fall of 1 to 2 millimeter after 3 months of surgery. So if you correct equally at the time of surgery, then you are going to get down like 1 to 2 millimeter of droop within 3 months. So you better overcorrect at the time of surgery so that when it falls down, it will come to a same height as the other eye. I think that's what I want to show, and I think the result looked pretty much good. And then I think this is what we do for ptosis surgery. But anyway, Ravi Shankar, it was a wonderful presentation. In such a short time, you cover everything, I think, and most of the important aspect of evaluation of ptosis. Thank you very much.
Thank you so much, doctor. So, uh, again, there is another question. So I would like to hit with another question. There is one question. She's asking for, sir, if the patient has bilateral ptosis, how the vertical fissure height helps to correct the ptosis?
uh, I think the
So,
question. Hello.
Ravi, so when the patient has bilateral ptosis, how I'm going to judge what amount of ptosis correction I need to make? That's what the question looks like.
Yeah. Yes. I also
So
think so.
what I do, yeah, I think what I do on those situations, I always put a, levator height about because in normal people, you know that the lid covers 1 to 2 millimeter of the superior limbus. That's what the normal people will have their upper eyelid position to be onto the cornea. So when you see 1 to 2 millimeter cornea is covered, so I usually leave overcorrected as I said. So probably I'll leave at the level of superior limbus on the both side in bilateral ptosis patients. But there are certain exceptions. If I think that this patient has a chance of exposure keratopathy, especially when the patient has third nerve palsy, when the child doesn't have very good extraocular motility, it may be a case of Duane retractor syndrome, or it may be a case of congenital third nerve palsy, where extraocular motility is not good and Bell's phenomenon is very bad. Then on those situations, I try to undercorrect my patients. I just leave the cornea, the pupillary area, so that patient will not have amblyopia or deprivation of the vision or a visual pathway. So I just open visual pathway on those situations. Those are special situations. Otherwise, I keep the lead height at somewhere at the superior limbus, so that it falls 1 to 2 millimeter after 3 months, and that is what is the normal height of the what is the normal height, normal position of the upper eyelid. That's what I do.
Okay, thank you so much, doctor. And there is another
So I'd
question.
like to clarify. Yeah.
Yes, yes, please.
I'd like to clarify the initial question that was answered by Ravi Shankar about the pseudotosis and then dermatochalasis and then ptosis, aponeurotic. Aponeurotic in dermatochalasis there is no ptosis actually. It is a pseudotosis. Dermatochalasis means excess falling of the upper eyelid down towards the visual axis. That's a dermatochalasis. Dermatochalasis is excess skin actually. It's not a ptosis. Because if you measure the interpalpebral fissure height, there is normal interpalpebral fissure height. But whereas in ptosis, you definitely will have less interpalpebral fissure height. That's what the difference between. So I just trying to show you. Can you see the Kapil? Can you see my screen now?
Yes, doctor. Yes, yes, we can see.
So this is a surgery. This is very interesting surgery of ptosis surgery that we did in Papua New Guinea. It's in the eastern highland of Papua New Guinea. We did a surgery. I and myself and then some of my team. One of my friend from US visited Papua New Guinea, which is very close to Australia. We did our voluntary work and we did more than I think 100 surgery in a week, all ptosis surgeries. And then they have very unique type of ptosis. It has not been explained in the book. We don't know what actually caused them ptosis. We did a biopsy, we did their genetic testing, and nothing came positive. So this was a unique thing that I want to share with you all. I flew myself in 2000, I think it was in 2015. We did a great outreach camp in Papua New Guinea. We not only do ICAM in Nepal, but also we do high volume oculoplastic ICAMs around the world. Yeah, what is the next question, Kapil? You have more question to ask?
Okay, doctor. Okay, there is a one question from the Smita Marin. Sir, I have seen the Ptosis woke up are not performed in the general clinic until its oculoplasty department. How important is it to Ptosis woke up in the eye clinic before referring to the further treatment?
No, it's really important to know how to assess a ptosis patient at a primary level or at a clinic level or at a secondary level hospital, because you have to counsel in order to get some faith from your patient. If you say I don't know about it and just refer the patient will not have a faith on you. So at least you can measure the levator function test and say you have very poor levator function, so I think you need to undergo a different surgery, which doesn't have a very good outcome as compared to a person who have a good levator function. Or similarly, you can also assess their protective mechanism like extraocular motility. You can check for bells, and then if somebody has very poor bells phenomenon, then you can again tell them that I think probably you cannot have as good eyelid opening as the normal people, because you have a poor protective mechanism like poor orbicularized tone, and then again your Bell's phenomenon is poor, and then extraocular motility is also limited. So you need to undergo surgery, but the eyelid opening is not going to be as good as a normal person. If you say that to the person, then they'll be happy to hear the same thing when they come to a person like us and we explain the same, and then they think that, oh, my previous doctor also said me the same thing. So now these people will have a great faith on you if you know how to evaluate a patient, and then also counsel a patient at anywhere at any level of the eye center or any level of the eye care provider that you are working with.
Okay. So, Doctor, I guess we have answered most of the question there. And Doctor, like, still, if we see the patient from the out of the center, or uh, I would say periphery or Himalayan regions or the village side, still there is a patient with the most of the children with the congenital ptosis and unilateral amblyopia. So still there is a lot of patient like who are not getting directly treatment for the ptosis. So if we is there any facility or we have any like as you say the camp or anything that from the national level as well or from the other NGO or INGOs that approaches to the villages or to the such type of patient?
Yes, Kapil, that's a great question about a pediatric ptosis. So pediatric ptosis, as I already mentioned, that it is a special condition. It's not like an adult where it doesn't bother when you do the surgery or when you refer the patient. But in the pediatric case, you need to make early referral to prevent from amblyopia. So it's not only the amblyopia in pediatric ptosis is not just because of stimulus deprivation, but also it is seen that somehow the child with ptosis will have some kind of astigmatism. Even though they don't have the stimulus deprivation, they may have astigmatism. I think it is about 10% of the child presenting with the pediatric ptosis will have some kind of a meridional amblyopia as well, or astigmatism induced amblyopia apart from the stimulus deprivational amblyopia. So I think it's really important to early detect and pick up the child as soon as maybe after the birth, and then refer the patient. As I said, that you need to take horsebug test, which is done very easily at the community level. Just show the light and then see if the light reflex is visible, or and if the pupil is not covered with the ptosis. You need to make out that, and then easily refer the patient from the community, anyone who sees at the community. But about your question, second question was, is there any initiative of NGO or other hospital or private hospital to initiate the screening of the children at the community level? for the congenital ptosis, I think that's a good idea. And then I have actually already started a program which is called Community Children Eye Program. It's under the construction phase. I am expecting it to be implemented by next 3 or 4 months, or at worst it should start at 6 months. So it not only actually see the ptosis patient at children, but also other associated problem that can lead to amblyopia, or uh, or it is also specially designed. The program is specially designed to pick up the amblyopia and also the congenital cataract. Retinoblastoma are our priority, and then also retinopathy of prematurity. I think these are some of the diseases which we have prioritized, and we are designing a program which is going to be launched very soon into the community. And then we are expecting it to do in two of the district in province number 1, which is Dhankuta and Sunsari. We are starting at Dhankuta and Sunsari. For all the children in Dhankuta and Sunsari, we are expecting to screen at least 100,000, which is 1 lakh children in a year. And we'll continue to do that for 2 years there, Dhankuta and Sunsari. And if this program success, or if this program shows good result, or if the results are promising, then probably we'll take it to throughout the province, and then again throughout the country. That's what we are expecting to do for newborn children's.
Okay, that's a great news, doctor. So there is
Yes.
another question for the it's for the Ravi sir. Sir, is any management available to correct the ptosis from the optometry side?
Yeah, so I think uh, like the doctor has told you, the complicated ptosis in which the surgical outcome is not good and surgically which cannot be done. So in that cases, what we can do is that we can make a cross glass for it to correct it. In cross glass, what we do, we make a fiber like thing in our spectacle, in the top of the spectacle in the rim, and that fiber, what it does, it act as a crutch and it presses the upper lid, it make a support over there, and finally it corrects the ptosis, it uplifts the upper lid. So this can be done in the optometry part. And in I think Dr. Ben can tell us that if a 100 patient, like 10 patient comes for the ptosis, only 6 or 7 cases can be surgically performed or less than that, and the rest of the case will be like complicated ptosis. So in that the optometry rules comes again by making a cross glass and making the patient happy.
Okay.
I
So I
agree, Ravi
guess
Shankar, but the number of crosses that you may need is less than what you said, because as I said, that when we went to a small island near to Australia, and then we did about 100 ptosis surgery. Out of that, and then we cancel about 3 or 4. That means 3 to 4% of the patient may need a cross, which is fitted into the glass. And then we also have started making the cross in our center. It's not a difficult job. It's just putting the plastic, or it's just putting the hard coat plano lens cutting, and then putting on the top of the glass rim, and then the other end will go and then pull the eyelid up. So it's kind of mechanical thing that we give to patients where we cannot do surgery. So which are the patients where we cannot do surgery is maybe a patient who is very old and who doesn't want surgery actually. So a person who refused surgery can go for that process. And then there are certain conditions, like as I said, the extraocular motility is very poor, and patient, if you think that patient cannot tolerate surgery because of exposure keratopathy after the surgery, and that's another indication that you make a process for the patients.
Okay, I guess we had answered this question. So I guess we had answered the most of the question. And if anybody have any question or you want to talk with the doctors, you can unmute yourself and ask the question. Before that, we are towards the ending the session. So, Dr. Bean, if you like to give some good notes towards our program or before ending the today's session.
Yeah, thank you, Kapil, and also Mero Eye team to invite me as a panelist today. And thank you, Ravi Shankar, for a wonderful presentation, and then audience for the questions. So I think we have raised a very important issue that each and everyone working at the community level or at the tertiary eye center should be aware of Ptosis evaluation. In that context, we also discuss very variety of problems that can happen after the surgery, and then that's where the need of careful evaluation is there. And then also we have discussed about pediatric ptosis, which is a special situation and which needs urgent care and then also urgent referral. I think we have discussed most of the thing that can be, I think, helpful for the viewers or listeners in this today's meeting. So thank you very much, everyone, for your participation and also for inviting me as a panelist. Thank you.
Thank you so much, Doctor, and thank you so much, Ravi sir. And before ending the today's session, I'd like to express my sincere gratitude towards the presenter, Mr. Ravi sir, and towards the Dr. Ben sir, and all the attendees. And also, I'd like to appreciate all the helping hands for the iTex program. Here with, I'm ending the today's session, requesting all you please provide review and feedback and stay safe. Keep in touch. Thank you so much. Uh, Ravi sir, do you want to
Yes,
put a few words before ending the
yes.
session?
Yes. So thank you, Kapil and Mero Eye care team for inviting me for a good session, and thank you very much, especially to Dr. Ben for enlightening the sessions and making the session so interactive. Thank you, sir. You are always a good teacher as well as a very good surgeon, and thank you for all
Thank
attendee to
you, Ravi.
thank you, sir. So thank you to all attendee for attending the session. Thank you very much.
Thank you so much.